We would like to discuss surgical containment in Perthes disease. Does it always work? In order to answer this question, we need to know what is good outcome in Perthes disease. And one of the important publications is by Stuhlberg and his colleagues, published in 1981 JBS American. And they classed the long-term outcome of Perthes disease HEPs into 5 classes according to the sphericity of the femoral head and the congruency of the hip joint. But because of the complexity of the system, Herring et al. And Weg et al. Used a modified version where they grouped class 1 and 2 spherical femoral heads into group A, class 3 aspherical or ovoid femoral head into group B, and flat femoral heads group 4 and 5, which have poor prognosis, into group C. But right now we know that only spherical femoral heads classes 1 and 2 have long-term good prognosis, and all aspherical femoral heads, whether class 3, 4, or 5, they all have poor prognosis. And according to a paper published by Larson and Herring in JBS 2012, 20-year long-term follow-up of Perthes disease patients, they found that only class 1 and 2 had low-rate secondary degenerative osteoarthritis, and class 3, 4, and 5 have high rate of secondary degenerative osteoarthritis. And that's why we say now only spherical HEPs will have good prognosis, and all aspherical HEPs will have poor prognosis. What are the prognostic factors in our surgical containment for Perthes disease? The most important are age at onset and the severity of the disease. And the severity of the disease can be quantified using MRI perfusion studies. And there are important publications by Harry Kim and his colleagues from Texas Scottish Rite, and they have developed the HEP-VASC software in order to quantify the extent of perfusion of the femoral head. We have the Salter-Thompson classification, which is an early X-ray classification system based on the subchondral fracture. We have the lateral pillar, but we need to wait until middle or late fragmentation stage, which is very late in treatment of Perthes disease. Modified Cottrell classification, we grouped Cottrell 1 and 2 into less than 50% head involvement, and group 3 and 4 into more than 50% head involvement, and last, femoral head extrusion, which is a very important factor. And femoral head extrusion can be quantified on X-rays using Reimer migration index, and we know that Reimer's migration index, more than 12% is abnormal and more than 20% is significant extrusion, can be quantified by bony acetabulum head index, which is a measure of the width of the bony acetabulum divided by the width of the femoral head, and if it is less than 75%, this is a significant extrusion, or cartilaginous acetabulum head index, which is exactly the same but using MRI scans and recently sonographic. Indications of surgical containment. Regarding the evidence-based indications, they are mainly from big 2 prospective studies by Herring et al. And Weg et al. And Herring et al. And Weg et al. Studies both are prospective studies. They have included 345 patients and 358 patients respectively. And in the Herring et al. Study, there were 5 treatment arms: no treatment, brace treatment, range of movement exercises, proximal femoral varus osteotomies or Salter osteotomy. And in the Weg et al. Study, there were physiotherapy, Scottish Rite abduction orthosis, or proximal femoral varus osteotomy. And both used modified Stuhlberg classification for the outcome. So, according to those 2 publications, the indications of surgical containment: if the age is less than 6 years, always we will try non-operative. And if it is more than 6 years, according to Weg et al., and 8 years, according to Herring et al., then if the femoral head involvement is more than 50%, or pillar B or pillar BC or C, then we should go for operative treatment. However, there are limitations for both studies. First of all, if you see this table from Herring et al., you have many subgroups with very small numbers of patients in each subgroup, which decreases the power of the study. And second, they considered class 3 Stuhlberg HEPs as a good outcome, which is not true so far. So if we looked at the publication from another perspective and we classed the HEPs into good outcome Stuhlberg 1 and 2 and poor outcome Stuhlberg 3 to 5, then we will have that. Pillar C, for example, had the worst outcomes with aspherical femoral head rates between 70 to 100% with operative treatment in both studies. What about timing of surgical containment? According to the publications from Benjamin Joseph in 2003, JPO, they have devised a new classification system based on the Waldenstrom stages that we know. So we know that the initial stage is sclerosis, the second stage is fragmentation, and the third stage is reconstitution, and they subgrouped each stage into two subgroups. The sclerosis into 1A and 1B according to the height of the epiphysis, and fragmentation, early fragmentation stage 2A, only one vertical or two vertical fissures, and then 2B, advanced fragmentation, and reconstitution 3A and 3B. And according to their study of the natural history of Perthes disease, there will be significant increase in epiphyseal extrusion, increased metaphyseal width, and metaphyseal changes and acetabular changes in late fragmentation stage 2B and reconstitution stage 3A and 3B. And there will be a reversible femoral head deformity, and that's why containment should be done by early fragmentation, stage 2A. So we should do containment in stage 1A, 1B, and 2A. And according to their studies, the age of the patient at onset, if it is less than 8 years, then we can start with observation and see what about the femoral head extrusion. If it is absent, then observation. If it is present, then containment. And in all children 8 years or above, they will just recommend containment surgery. And containment surgery should be done early in the disease, stage 1A, 1B, or 2A. But I'm interested in looking at tables and numbers and analyzing them. And in their study, they had 317 patients underwent surgery out of 702 Perthes disease. And only 107 patients were available for analysis of the Beller classes and its relation to the head shape at the final outcome. And interestingly, even with their protocols, about 56% of the heads were aspherical, were bad in shape, but no adequate data about how many had early surgery within this subgroup. And there's another big difference in the recommendations of Benjamin Joseph compared to our treatment protocols. First of all, they do open wedge subtrochanteric varus osteotomy with derotation or extension. They do always trochanteric epiphyse basis, and all of their patients will be non-bearing until late stage 3, stage 3B. So according to their natural history, those patients might be non-bearing for about 300 days or more than 300 days, about a year, which is non-practical in most of the cases. So could Joseph et al. Results be attributed to only containment, or there's an effect of the prolonged post-operative non-bearing protocol? Because we know from a piglet model, an animal model developed by Harrican and Texas Scottish Rite, if we amputated the hind limb of the animal, of the piglet, then this limb will be non-bearing, and there's a significantly less flattening of the affected epiphysis and greater revascularization and bone resorption rate. This is an example. One of the patients, 8 years and 3 months, male patient who was in stage 1B, and he had in our hospital early surgery, containment with a proximal femoral varus osteotomy according to Benjamin Joseph recommendations, and then by fragmentation it was pillar C, and 7-year follow-up. He had aspherical femoral head, and he's on the waiting list right now for total hip replacement. Surgical containment technique. We have pelvic-sided containment with Salter's osteotomy, triple and nominate osteotomy, or Diga osteotomy. We have femoral-sided, proximal femoral varus, or we have combined. I was trained in sick kids, and they do always pelvic-sided, and the advantage, it doesn't shorten the limb, nor affects the length of the hip abductor muscles, and complications like inadequate femoral head coverage, loss of acetabular position, failure of fixation, and decreased range of motion might be encountered. So this is one of my patients in Manchester. You can see a 6-year-and-a-half-old lady had left DDH and Perthes disease at the same time. So I've just gone to a containment with correction of the acetabular dysplasia using Diga osteotomy, and this is her 18-month follow-up. She's kept the fragmentation stage and healed. Then proximal femoral varus osteotomies. We usually do 20 degrees proximal femoral varus osteotomy. You can use looking head plate like this or any other kind of fixation. The disadvantages are excessive proximal femoral varus and shortening, abductor weakness, abductor ledge, overriding greater trochanter, and lateral impingement. This is another patient of mine, 9-year and 10-month-old boy, insulin-dependent diabetic, and stage 1B disease, and early containment surgery with a proximal femoral varus osteotomy, and this has 10-month follow-up and 2-year follow-up. Bilateral Perthes disease, less attention in the literature about bilateral Perthes disease, but about 8 to 24% of the patients might have bilateral Perthes disease. It significantly affects younger children, and it can be concurrent onset or sequential onset, and unfortunately it carries worse prognosis, and in particular sequential bilateral Perthes disease has the worst outcome with double rate of flat femoral head at healing, whatever the age. And this is one of my patients. You can see 4.5-year-old with the right Perthes disease. Then at the age of 5, he had bilateral Perthes disease with significant extrusion and subluxation, done bilateral proximal femoral osteotomies, and this is his 14-month follow-up. You can see that the hips are now well reduced and congruent, and the right side is already healing, and there's partial healing on the left side. So, in conclusion, we know so far that most important prognostic factors in our surgical containment are age and the severity of the disease. Early surgery is advisable, and post-operative non-weight bearing protocol might be of help, but we need more evidence from level 1 and 2 research. Thank you.